Unexplained weight loss and declining appetite in elderly individuals are often subtle but deeply significant signals that the body is entering a stage of transition, sometimes pointing toward the final year of life. When an older person begins to lose weight without actively trying to, and when they no longer feel the desire to eat even foods they once enjoyed, it reflects more than just a casual change in habits. It indicates that the body is undergoing internal changes that may no longer support the same nutritional intake or energy balance it once could. This kind of weight loss is not usually due to dieting or exercise. Rather, it happens gradually, almost invisibly at first, and then becomes noticeable over weeks or months. Family members may initially dismiss it as normal aging, but in reality, the unexplained reduction in body mass and appetite is a red flag that the body is conserving its remaining strength for essential functions, letting go of non-essential processes like maintaining muscle or fat storage. One important reason behind this decline is the slowing of metabolism. As people age, the metabolic rate naturally decreases, meaning the body needs less energy to function. But when weight loss is unintentional and accompanied by loss of appetite, it often suggests that the digestive system is no longer absorbing nutrients as effectively or that the body's ability to process food is compromised. For instance, conditions like reduced stomach acid, chronic illnesses such as cancer or heart failure, or even age-related decline in organ function can make eating less desirable and less efficient. The taste buds themselves change with age, and food may no longer bring the same satisfaction, which only compounds the reduced drive to eat. Together, these small shifts accumulate into a larger picture. The body is slowly withdrawing from its earlier energetic demands and signaling that it is preparing for a different stage of life. Emotional and psychological factors also play a role in unexplained weight loss and appetite decline. Elderly individuals may feel isolated, lonely, or depressed, especially if they have lost close companions or no longer participate in meaningful activities. Eating is often a social event, and without companionship, meals may feel empty or burdensome. Depression in older adults is frequently underdiagnosed, and its effects on appetite can be profound. Furthermore, cognitive decline or early dementia can alter food preferences or reduce the ability to remember when to eat, leading to missed meals and a gradual reduction in nutritional intake. Families may notice untouched plates, half-finished meals, or even resistance to eating, not out of stubbornness but because the act of eating itself no longer feels essential to the person experiencing this stage of decline. On the physical side, certain illnesses that are common in the elderly exacerbate this situation. Chronic kidney disease, liver problems, advanced lung or heart disease, and cancers often lead to what is known as cachexia, a syndrome of weight loss, muscle wasting, and fatigue that cannot be reversed simply by eating more. The body in this state does not process nutrients in the same way, so even if the elderly person tries to eat, their body may not hold onto the calories or proteins. This makes caregiving especially challenging, as family members often assume that feeding their loved one will restore strength, when in fact, the underlying problem is not just about food but about the body's overall decline. This disconnect between what families expect and what the body can actually do often leads to frustration, guilt, and confusion. Another dimension to consider is the role of medication. Elderly people are frequently on multiple prescriptions for various conditions, and many of these drugs come with side effects that suppress appetite or alter taste. For example, certain antibiotics, chemotherapy drugs, or pain medications can leave a metallic taste in the mouth, create nausea, or cause digestive discomfort. Over time, this discourages eating, further contributing to weight loss. Some medications also cause drowsiness or fatigue, which reduces the motivation to prepare or consume meals. When combined with the natural slowing of bodily processes, this can accelerate the decline in both appetite and body mass, making it increasingly evident that the person is transitioning into a more fragile state of health. The consequences of unexplained weight loss and declining appetite are not limited to appearance or numbers on a scale. They impact the overall resilience of the body. Weight loss often means the loss of muscle, which leads to reduced mobility and strength, increasing the risk of falls and fractures. Lower appetite translates to reduced intake of essential vitamins and minerals, which compromises the immune system, making the person more vulnerable to infections. This vulnerability becomes a vicious cycle. An infection reduces appetite further, and reduced nutrition weakens the ability to fight infections, leading to repeated hospitalizations or prolonged recovery times. Families who observe this pattern should recognize that what seems like a small issue, eating less, is actually a major warning sign of the body's weakening defenses. From a caregiving perspective, these changes also shift the focus of how to best support the elderly person. Instead of forcing large meals, caregivers may need to adapt by offering smaller, nutrient-dense portions that are easier to consume. Soups, smoothies, and soft foods may be more appealing than heavy or complex meals. The goal often changes from trying to reverse the weight loss to providing comfort, maintaining dignity, and ensuring that the person feels cared for without pressure. Hospice and palliative care specialists often emphasize that in the final year of life, quality is more important than quantity, and sometimes the kindest approach is to respect the body's natural signals rather than trying to fight them at all costs. Families need to be reassured that declining appetite and weight loss are not failures in caregiving, but natural processes that accompany the body's final journey. It is also worth noting that while not every elderly person who experiences unexplained weight loss and appetite decline is necessarily in their final year, the presence of these signs should always prompt closer attention. Doctors may recommend screenings to rule out treatable causes such as thyroid problems, vitamin deficiencies, or gastrointestinal disorders. However, when medical interventions show limited success and the decline continues, it often signals that the body is gradually shutting down. At this point, conversations about end-of-life care, advanced directives, and emotional support for both the individual and their family become crucial. Ignoring these signs may lead to unnecessary stress, hospitalizations, and invasive treatments that do not improve quality of life. In essence, unexplained weight loss and declining appetite are not just casual observations but profound indicators of an elderly person's internal state. They reflect both physical and emotional changes that often accompany the final year of life. Recognizing these signs early allows families to shift their perspective, from trying to fix what cannot be fixed, to focusing on comfort, connection, and meaningful time together. Rather than seeing weight loss as something to battle, it can be understood as the body's way of signaling that it is nearing the completion of its natural cycle. Accepting this truth, while difficult, can bring peace and help loved ones provide care that honors the dignity of the person during their most vulnerable stage. Frequent hospitalizations, infections, or health setbacks in elderly individuals are often among the clearest signals that their body is reaching a stage of fragility where recovery becomes increasingly difficult. When someone who once managed their illnesses well begins to require repeated trips to the emergency room or stays in the hospital, it is rarely just coincidence. Instead, it usually reflects that the body's resilience, or ability to bounce back from challenges, is fading. In younger years, a bout of pneumonia, urinary tract infection, or even a fall might be manageable with rest and treatment. But in advanced age, the same incidents can set off a spiral of complications that the body cannot fully recover from. This cycle of repeated illness and hospitalization becomes a warning sign that the final chapter of life may be approaching. The immune system plays a central role in this process. As people age, the immune response naturally weakens, a condition known as immunosenescence. This means that infections that would once be considered minor, like a cold, a skin wound, or a urinary infection, can now become serious threats. Elderly individuals may develop sepsis from infections that go unnoticed for too long, or they may need intravenous antibiotics to treat something that was once easily managed at home. When hospital visits become frequent, it is often because the immune system can no longer mount a strong enough defense, leading to repeated flare-ups that drain what little strength remains. Families often notice that each hospital stay leaves their loved one weaker than before, requiring longer recovery times or resulting in permanent declines in mobility, cognition, or independence. Chronic conditions also contribute to these recurrent setbacks. Many elderly people live with long-term illnesses such as congestive heart failure, chronic obstructive pulmonary disease, kidney disease, or diabetes. Over time, these conditions advance to a point where they no longer respond effectively to medication or standard care. For instance, heart failure may cause repeated fluid buildup in the lungs, leading to hospital admissions for shortness of breath. Similarly, advanced kidney disease can result in frequent hospitalizations for electrolyte imbalances, infections, or dialysis-related complications. Each time a chronic disease flares, it stresses the body further, and the cumulative toll of these setbacks accelerates decline. Even when medical teams manage to stabilize the immediate crisis, the underlying trajectory remains downward, with each setback nudging the person closer to the body's natural limits. Hospitalizations themselves can sometimes worsen the situation. Elderly patients are more vulnerable to hospital-acquired infections such as pneumonia or bloodstream infections, especially if they require invasive treatments like catheters, ventilators, or intravenous lines. Prolonged bed rest in the hospital can lead to muscle wasting, increased risk of blood clots, and loss of mobility. Cognitive decline is another common consequence, with many older adults experiencing delirium during hospital stays due to disorientation, medication effects, or disrupted sleep. What begins as an effort to restore health can inadvertently accelerate frailty, leaving the person weaker and less capable of returning to their previous quality of life. This phenomenon is often referred to as the post-hospital syndrome, where the stress of hospitalization itself contributes to further decline. Frequent infections are another piece of the puzzle. Urinary tract infections, for example, are very common in elderly individuals, especially those who are bedridden or use catheters. These infections can quickly spread to the bloodstream, becoming life-threatening. Pneumonia is another frequent cause of hospitalization, particularly in those with swallowing difficulties or chronic lung disease. Skin infections from pressure sores or minor injuries can escalate into severe complications because of poor circulation and weakened immunity. Repeated infections not only weaken the body but also erode the individual's overall willpower and energy, making each successive illness harder to fight. Caregivers often notice that after several infections in a row, the elderly person begins to withdraw, eat less, and show less interest in activities, signaling a deeper decline. The emotional and psychological impact of frequent hospital visits cannot be underestimated either. For the elderly, hospitals are often overwhelming places: bright lights, unfamiliar environments, constant noise, and frequent medical interventions can be distressing. Repeated hospitalizations may create fear, anxiety, or even a sense of hopelessness. Many elderly individuals begin to dread hospital visits, knowing that each one brings discomfort, loss of independence, and sometimes invasive procedures. Families, too, feel the emotional toll, watching their loved one go through cycles of suffering without true recovery. At some point, the realization sets in that medical care is no longer restoring health but merely prolonging the process of decline, which can be a very difficult truth to face. At a practical level, frequent hospitalizations often mark the time when families and doctors begin discussing end-of-life care options. When setbacks become the norm rather than the exception, the focus of care may shift from aggressive treatments to comfort and quality of life. Palliative care and hospice services become relevant, offering support not just for physical symptoms but also for emotional, spiritual, and family needs. Instead of rushing the person to the hospital at every setback, families may choose to manage infections, pain, or other complications at home with medical guidance, prioritizing peace and dignity. Recognizing this turning point requires sensitivity and courage, as families often feel torn between wanting to do everything and accepting that the natural course of life is nearing its end. Medication use also complicates the picture. Elderly individuals often take multiple prescriptions, and during hospital stays, new medications are frequently added. This polypharmacy increases the risk of drug interactions, side effects, and confusion about dosing. Sometimes, the very medications intended to stabilize one condition create problems elsewhere, such as excessive drowsiness, dizziness, or increased risk of falls. Each new prescription adds complexity, and managing them becomes increasingly challenging for both the individual and caregivers. Over time, this medication burden can become another factor contributing to repeated hospitalizations, creating a cycle that feels impossible to break. It is important to understand that not every hospital visit indicates that the end of life is near. Some elderly individuals bounce back from acute setbacks and live for years afterward. However, when hospitalizations become a pattern, especially when they occur within short intervals, it is a strong indicator that the body is in decline. The inability to recover fully between episodes is what truly signals that the final year may be underway. Families who notice this pattern should pay close attention, not just to the physical symptoms but also to the overall trajectory of health, energy, and resilience. When the curve points steadily downward despite medical intervention, it is time to prepare emotionally and practically for what lies ahead. Ultimately, frequent hospitalizations, infections, and health setbacks represent more than isolated medical events. They are a narrative of the body's diminishing capacity to sustain itself. Each hospital stay, each infection, each health crisis is like another chapter in a book that is nearing its conclusion. Recognizing this reality allows families to make more compassionate choices, focusing less on extending time at all costs and more on making the time that remains meaningful. Whether that means ensuring comfort at home, surrounding the elderly person with loved ones, or simply respecting their wishes about medical interventions, the shift in perspective can transform what feels like endless suffering into a more peaceful and dignified journey. Noticeable cognitive decline or personality changes in an elderly person can be among the most distressing and telling signs that the body and mind are moving into the final stages of life. Unlike physical symptoms such as weight loss or reduced mobility, changes in memory, thinking, or behavior strike at the very core of a person's identity, leaving family members feeling as though they are slowly losing the essence of their loved one even before physical death occurs. These shifts may appear gradually at first. A forgotten appointment, misplaced objects, a moment of confusion about the time of day. But over months, they may grow more pronounced, manifesting as disorientation, difficulty recognizing familiar faces, mood swings, or even uncharacteristic anger or apathy. While mild memory lapses can be a normal part of aging, more severe cognitive decline often signals that the brain itself is deteriorating due to age-related conditions or the body's overall decline in health. One of the most common culprits behind these changes is dementia, particularly Alzheimer's disease. In its early stages, dementia may appear subtle, with small lapses in memory or decision-making. But as it progresses, the effects spread into all areas of mental functioning. The elderly person may have trouble finding the right words, lose track of conversations, or struggle with simple daily tasks like managing finances or preparing meals. In the final stages, dementia often robs individuals of the ability to communicate, recognize loved ones, or even understand where they are. This erosion of cognitive ability not only creates immense emotional pain for families but also reflects that the brain is no longer able to perform its vital functions, an indicator that the end of life may not be far away. Cognitive decline, however, does not always stem from dementia alone. Conditions like strokes, Parkinson's disease, brain injuries, or even prolonged malnutrition and dehydration can accelerate mental deterioration. When an elderly person who once had sharp reasoning and stable emotions suddenly becomes forgetful, confused, or erratic, it may signal a deeper medical issue. For example, repeated small strokes, sometimes called silent strokes, can cumulatively damage brain tissue, leading to sudden or stepwise declines in cognition. Similarly, oxygen deprivation from heart or lung problems can impair brain function, causing confusion or memory loss. In many cases, these changes coincide with other signs of the body shutting down, such as frequent infections or weight loss, painting a larger picture of systemic decline. Personality changes can be even more striking than memory loss. Families may notice that their once cheerful and sociable loved one becomes withdrawn, irritable, or apathetic. Someone who was calm and patient may suddenly become angry, paranoid, or agitated without obvious reason. This happens because as the brain deteriorates, it affects not only memory but also emotional regulation. The frontal lobes, which control judgment, self-restraint, and social behavior, often weaken first, leading to unpredictable or uncharacteristic behavior. For caregivers, this can be heartbreaking and exhausting. They may feel as though they are caring for a stranger, not the parent, spouse, or sibling they once knew. Such changes are not a matter of choice on the part of the elderly person. Rather, they reflect the biological changes in the brain that accompany the later stages of decline. Confusion about time, place, and identity is another hallmark of significant cognitive decline. An elderly person may wake up in the middle of the night believing it is morning, insist that they need to go to work despite being long retired, or fail to recognize the house they have lived in for decades. These episodes of disorientation often become more frequent as decline progresses, creating safety risks such as wandering outside unsupervised or forgetting how to use household appliances safely. Families often find themselves needing to provide constant supervision, which can be emotionally and physically draining. These behaviors not only signify cognitive decline but also highlight that the person is moving closer to a stage where independence is impossible and full-time care may be necessary. Delirium, or sudden acute confusion, is another aspect often seen in elderly individuals nearing the end of life. Unlike dementia, which progresses gradually. Delirium can appear abruptly, often triggered by infections, medications, dehydration, or hospitalization. A person experiencing delirium may appear suddenly disoriented, hallucinate, or swing rapidly between agitation and drowsiness. Delirium is a serious condition and often a marker that the body is under severe stress. In the final year of life, episodes of delirium may become more frequent and harder to reverse, signaling that the body and mind are becoming increasingly fragile. Beyond the medical explanations, cognitive and personality changes have a symbolic weight in the journey toward life's end. They often represent a loosening of ties between the individual and the external world. When an elderly person forgets names, loses interest in conversations, or no longer recognizes familiar surroundings, it can feel as though they are already partly letting go of this life. This perspective is often shared by palliative care experts, who see these changes not simply as medical decline but as part of the natural process of detachment that precedes death. Families, though deeply saddened, may find some comfort in viewing these changes as part of a larger transition rather than solely as a loss. The practical consequences of cognitive decline are profound. Decision-making becomes impaired, which can complicate medical choices, financial management, and even daily routines. Elderly individuals may forget to take medications, take them multiple times, or resist them altogether. They may become vulnerable to scams or make risky decisions that they would never have made in their clearer years. For families, this raises the need for guardianship, advanced directives, and legal preparations to protect their loved ones' interests. At the same time, the unpredictability of mood swings and behavior changes can create emotional strain, especially if the elderly person becomes verbally or physically aggressive toward those trying to help. Caregivers must balance patience and compassion with their own need for rest and support, recognizing that these changes are symptoms of decline rather than deliberate actions. Infections and hospitalizations often worsen cognitive decline, creating a downward spiral. Each time an elderly person is hospitalized for pneumonia, urinary tract infection, or heart failure, they may come home more confused than before. Some never regain their prior level of mental clarity, even after the physical illness is treated. This phenomenon highlights how fragile the aging brain becomes. Even small stresses can push it into lasting decline. Families who notice this pattern, confusion worsening after each medical crisis, are often witnessing the progression toward the final stages of life. Despite the challenges, there are ways to provide comfort and support during this stage. Familiar routines, calm environments, and gentle reassurance can help reduce confusion and agitation. Playing favorite music, showing old photographs, or maintaining simple rituals may provide moments of recognition and joy, even if brief. For families, these moments become precious, as they provide glimpses of the person they remember amidst the fog of decline. As difficult as it is to accept, these efforts are less about restoring full cognitive function and more about preserving dignity and connection in the time that remains. Ultimately, noticeable cognitive decline and personality changes serve as profound warnings that the end of life may be approaching. They reflect not just the aging of the brain but the overall weakening of the body, its systems, and its ability to sustain the individual's identity as it once was. Recognizing these signs can help families shift from seeking cures to offering comfort, from trying to hold on tightly to accepting the natural course of life. While the changes may feel like a painful loss, they also provide an opportunity for families to cherish the essence of their loved one, to offer unconditional love, and to walk with them gently through the final phase of their journey. increasing weakness, reduced mobility, and loss of independence in elderly individuals are some of the most visible and heartbreaking indicators that the body is nearing the end of its natural journey. Unlike subtle signs such as appetite changes or shifts in mood, weakness and immobility are plain to see, often altering daily life dramatically. What begins as small struggles, taking longer to stand up from a chair, using a railing on the stairs, or needing to rest after walking a short distance, can evolve into profound frailty where even the simplest activities, such as bathing, dressing, or moving from bed to chair, require assistance. This steady decline is not just a matter of aging joints or tired muscles. It reflects the body's overall diminishing ability to sustain itself, an unmistakable signal that the final stages of life may be drawing closer. Weakness in the elderly often stems from a combination of factors. Muscle mass naturally decreases with age, a process known as sarcopenia. In younger people, exercise and diet can slow or even reverse this process, but in advanced age, the loss of muscle becomes more difficult to overcome, especially when appetite and nutrition are already in decline. Chronic diseases such as heart failure, cancer, and lung disease further sap strength by demanding more energy from the body than it can replace. Repeated hospitalizations also contribute, as bed rest accelerates muscle wasting and reduces stamina. Over time, the elderly person's once strong body loses resilience, making daily tasks exhausting or impossible. What families witness is not just weakness in the physical sense, but a visible sign that the body is withdrawing from its former vitality. Reduced mobility is another profound marker. At first, an elderly person may walk more slowly or use a cane for balance. Soon, they may require a walker, and eventually, many rely on wheelchairs or become mostly bedbound. Each step in this progression represents not only a loss of movement but also a loss of independence. The ability to get up, move around, and engage with life outside the home diminishes, often leading to isolation. Falls become a major risk, as weakened muscles and poor balance make even short walks hazardous. A single fall can result in fractures, head injuries, or long hospital stays, further accelerating the cycle of decline. Families often notice that after a serious fall, their loved one never fully recovers, both physically and emotionally, and this turning point can mark the beginning of a much steeper descent toward the end of life. The emotional impact of losing mobility is enormous. For many elderly people, independence is deeply tied to self-worth and dignity. Being able to dress oneself, use the bathroom without help, or prepare a simple meal are more than just tasks, they are symbols of autonomy. When these abilities fade, the elderly person may feel like a burden, leading to sadness, frustration, or even depression. Some resist help, insisting on trying to do things alone, only to injure themselves. Others may withdraw, preferring to stay in bed rather than confront the struggle of moving around. For families, watching this loss is painful, as it feels like witnessing the gradual shrinking of a life once filled with activity and purpose. Loss of independence also reshapes family dynamics. Caregivers often need to step in to provide increasing levels of support, from cooking and cleaning to assisting with bathing, toileting, and feeding. This role reversal, children caring for parents, spouses taking on round-the-clock responsibility, can be both emotionally and physically exhausting. It also highlights the irreversible nature of decline. While medical treatment may help with specific symptoms, no amount of intervention can fully restore independence once it has been lost due to advanced frailty. Families often find themselves faced with difficult choices about long-term care, assisted living, or hospice, recognizing that their loved one is entering a phase of life where comfort and dignity must take priority over attempts at full recovery. From a medical perspective, increasing weakness and immobility often indicate that the body's systems are failing in coordination. The heart may no longer pump efficiently, lungs may not deliver enough oxygen, kidneys may filter waste poorly, and the brain may struggle to regulate these processes. Together, these failures manifest physically as exhaustion, weakness, and loss of stamina. Even simple activities like eating or speaking may tire the person. Bedbound individuals often develop secondary complications such as pressure sores, blood clots, or pneumonia, all of which further compromise health and increase the likelihood of repeated hospitalizations. The cycle becomes self-reinforcing. Immobility leads to complications, complications worsen weakness, and weakness deepens immobility. At this stage, the body is clearly signaling that it no longer has the strength to sustain itself as it once did. There is also a symbolic layer to the loss of mobility and independence. Movement represents engagement with the world, going outside, meeting people, enjoying hobbies. As mobility decreases, the elderly person's world shrinks, often to a single room or even a bed. This physical narrowing often parallels an emotional or spiritual narrowing, where the person begins to turn inward, focusing less on external activities and more on reflection, rest, and eventually letting go. Families sometimes interpret this shift as giving up, but it can also be understood as a natural stage of preparing for the end. In many cultures, reduced activity near the end of life is seen as part of the body's wisdom, conserving energy for the essential functions that remain. The practical implications of increasing weakness and reduced mobility are profound. Homes may need to be adapted with grab bars, ramps, or hospital beds. Care schedules must adjust, often requiring multiple family members or professional caregivers to share responsibilities. Financial burdens can increase, with costs for medical equipment, in-home care, or facility placement. Emotionally, family members may struggle with guilt, wondering if they are doing enough, or with grief, realizing that their loved one is no longer able to live as they once did. Yet within this difficult stage also lies the opportunity for deeper connection. Assisting with personal care can become a tender act of love, offering moments of closeness and intimacy that may not have been present before. At the same time, families must come to terms with the reality that medical intervention has limits. Physical therapy, medication, and assistive devices may provide temporary improvements, but they rarely restore full independence in the final stages of life. The focus often shifts to preventing pain, providing comfort, and preserving dignity. This may mean accepting that the elderly person will spend most of their time resting, that meals will be smaller and simpler, and that conversations will replace activities as the primary way of sharing time together. Hospice care often becomes valuable at this stage, offering guidance and support for both the elderly person and their caregivers. Ultimately, increasing weakness, reduced mobility, and loss of independence are not just physical symptoms but profound markers of life's closing chapter. They signal that the body is no longer able to maintain the strength and energy required for active living. They transform daily routines, family roles, and emotional landscapes, creating both challenges and opportunities for compassion. Recognizing these changes as part of the natural process of decline allows families to adjust their expectations, shifting from trying to restore what has been lost to embracing the time that remains with gentleness and love. Though difficult, this stage offers a chance to honor the elderly person's journey, to provide comfort in their vulnerability, and to walk alongside them with patience and respect as they approach the final transition of life.